Welcome to my presentation on seizures. This presentation will focus on generalized tonic-clonic seizures. So my presentation will focus on and reference particularly New South Wales ambulance protocols, and it will include a general overview of seizures with a focus on, as I said, generalized tonic-clonic seizures. It will include information on pathophysiology, history and assessment, clinical features and findings, treatment options, and we'll highlight the role of a senior clinician. So the pathophysiology of seizures. A seizure can be defined as an inappropriate and disorganized episode of electrical discharge of brain neurons resulting in abnormal neurologic function. Underlying causes of seizure activity include epilepsy, a condition in which patients experience recurrent seizures due to lower seizure threshold. Primary or idiopathic is no clear cause can be identified. Secondary seizures are the result of identifiable neurological conditions that include a brain lesion or mass, head injury or stroke, and alcohol withdrawal. There are currently two major classifications of seizures. They include generalized and partial. Generalized tonic-clonic seizures. The complex pathophysiology of generalized seizures is caused by the simultaneous activation of the cerebral cortex caused by an electrical discharge beginning deep within the brain. Typically, generalized seizures present in the form of sudden loss of consciousness and changes in motor responses, including involuntary jerking of the body and peripheries. Tonic-clonic seizures are the most well-known type of generalized seizure. Patients experience two phases of the seizure, including the tonic phase, in which the patient becomes rigid and they fall to the ground. Following this, they experience the clonic phase, which involves whole body jerking. Generalized tonic-clonic seizures last for approximately 1 to 2 minutes and are followed by a postictal period of significant confusion and fatigue. Obtaining a thorough history is essential in developing a provisional diagnosis for a patient presenting with a seizure. Clinicians should focus their questions to bystanders or witnesses and then onto the patient once they have recovered. Clinicians should attempt to obtain a thorough history and description of the patient presentation by any witnesses or bystanders if the seizure has resolved prior to paramedics arriving on scene. This should include a description of the seizure or specific characteristics of the seizure if available. They should determine if the patient suffered a fall or any traumatic injuries during the seizure. They should ascertain if the patient is currently taking any anticonvulsant medication, if they have been compliant with their medication, or if they have had any recent medication changes. Determine if the patient has a history of seizures, if they are known epileptic, or if they have any health issues that may have triggered a seizure, e.g., brain tumor, diabetes, recent injury or illness, or any recent infections. They should obtain information on the patient's seizure history, including, is this their first presentation, or when was their last seizure? Do their seizures normally self-resolve, or do they require medication or intervention? And are they known to have any recurrent seizures? It's important that paramedics get the best and most thorough history available in order to make sure they have the best understanding of this specific patient's presentation of seizure. The clinical features of a tonic-clonic seizure include witnesses reporting or paramedics citing shaking or jerking of the patient, an abrupt onset or termination, incontinence of urine, evidence of oral injury including tongue biting, evidence of diaphoresis or sweating, tachycardia, confusion or changes in behavior, and altered GCS. Physical examination. Airway management is one of the most important factors during management of a patient having a seizure. Patients are high risk of pulmonary aspiration during a seizure and suction may be required. Breathing. Patients are typically become apneic during a tonic-clonic seizure, so paramedics should prepare to administer supplemental oxygen and must anticipate the need for assisted ventilations if cyanosis, a low respiratory rate, or poor respiratory effort is present. Circulation. Paramedics should assess patient circulation and monitor the patient's heart rate and blood pressure. Typically, patients will present in a tachycardic rhythm during or following a seizure. Disability. Clinicians should assess and reassess patients' GCS and level of consciousness following a seizure. C-spine. Assessment and management of patient C-spine, including application of a hard collar or manual inline stabilization, may be required if the patient has injured their neck during the fall. Secondary survey. Paramedics should ensure they complete a full secondary survey or nose to toes and assess the patient for any traumatic injuries, including C-spine tenderness, back pain, head injury, or limb fractures/injury, particularly shoulder dislocation, mouth/dental trauma. They should complete a focused neurological assessment, including pupil assessment, a fast exam, signs of altered neurology, loss of peripheral sensation, movement, and circulation. They should always complete a full set of observations and they should be repeated every 5 minutes. These include heart rate, blood pressure, blood glucose level, temperature, capnography, an ECG, and oxygen saturations. Pharmacology. The primary pharmacological intervention for seizure presentations in the pre-hospital setting is benzodiazepines. New South Wales Ambulance Service currently use midazolam. The primary alternative currently used by other services is diazepam. Midazolam is currently the first-line treatment in New South Wales Ambulance for the treatment of seizures. Midazolam is a short-acting benzodiazepine that acts as a central nervous system depressant. Benzodiazepines increase the inhibitory action of gamma-abutaroic acid GABA receptors, which results in muscle relaxation and sedation. Midazolam should be administered to any patient who has been actively seizing for over 5 minutes or who has had recurrent seizures with insufficient recovery time. The current New South Wales ambulance doses include. So for a patient over the age of 16, the IM dose is 5 milligrams undiluted to be repeated every 5 minutes up to a maximum dose of 15 milligrams. For a patient aged over 16, the IV dose is 2.5 milligrams diluted. So that's 1 mil of the drug drawn up, which is 5 milligrams, diluted with 4 mil, repeated every 5 minutes with a maximum dose of 15 milligrams. For patients under 16, they should receive 0.3 milligrams per kilo intranasally via the MAD device. Or alternatively, they can receive an IM dose 0.5 milligrams per kilo repeated every 5 minutes up to a maximum of 15 milligrams or 0.45 milligrams per kilo. Or alternatively, again, they can receive an IV or IO dose of 0.15 milligrams per kilo, diluted bolus, maximum bolus of 2.5 milligrams, repeated every 5 minutes to a maximum dose of 0.45 milligrams per kilo or 15 milligrams. Oxygen. Patients are typically apneic throughout the duration of a seizure and should be administered supplemental oxygen if there are signs of cyanosis, hypoxia, or decreased oxygen saturations. Paramedics should be prepared to support patients' ventilations with a bag valve mask if the patient is showing signs of decreased respiratory effort. So I've included here the New South Wales ambulance protocol flowchart. So it starts here at the top. Patient care, including history and key findings, which we've highlighted earlier in the slideshow. They should protect the patient from injury and consider any underlying causes and treat per that specific protocol. Going down, we've got administer midazolam, and as stated earlier, that's if the seizure is longer than 5 minutes or they're having recurrent seizures with insufficient recovery time. To treat associated conditions, so that'd be hypoglycemia, hypothermia. And then it's quite non-specific, but it then says to transport or to not transport, depending if the patient has any red flags or exclusion criteria, which is noted on the side there. So it would depend on the presentation of the seizure, if it's their first or second, if they're known to have seizures, what the underlying causes may be, as to whether or not the clinician decides to transport the patient. And then again, it says down there, repeat observations regularly and repeat physical examinations. So relevant investigations. An ECG. An ECG is important for clinicians to consider any underlying cardiac causes or indications of electrolyte imbalances. Blood glucose. A blood glucose should be conducted on all patients, but specifically seizing patients. All patients presenting with a seizure should have their BSL tested to rule out any underlying hypoglycemia or hyperglycemia. ISAT testing. New South Wales currently don't have ISAT testing pre-hospitally, but if in the future it does come in, it can aid clinicians' differential diagnosis and highlight any electrolyte imbalances or potential indications of infection that could be contributing to the seizure. And then some in-hospital investigations. A lumbar puncture can help diagnose a spinal infection, and an EEG is regularly undertaken if patients are having recurrent seizures or don't yet have a diagnosis, so they can be used to diagnose non-convulsive status EP or status EP. So transport making decision. Patients with airway compromise should be transported to the nearest ED capable of advanced airway management, which in most circumstances should be every emergency department that accepts ambulances. But obviously potentially some rural situations that might not be the case, and they may require air retrieval. If patients have not adequately recovered from a seizure or are having recurrent seizures or are in status, they should be transported under emergency conditions, and the code 3 or pre-alert should be passed to the receiving hospital with patient's details of condition. So new presentations of seizure should always be transported to the emergency department for further investigation and to identify what potentially has caused the seizure. However, patients with history of epilepsy or history of seizure may be eligible for referral, which will obviously require a more prolonged investigation and assessment on scene by the paramedic, but can include things like patients who have previously presented with febrile convulsions, patients who have had, it's a well known to have seizures, and there's not been anything different from what their normal presentation would be. So things like that can generally be left at home if they're left in care of a responsible adult or guardian. So the leadership role, the primary things I've listed here is airway management. Senior clinicians or ICPs should always be prepared for the potential requirement of an advanced airway management in a seizure patient. Seizure presentations are high risk of aspiration and may require advanced suctioning and intubation, and that may need the skills of the ICP. Pharmacological intervention. Advanced pharmacology may be required and should be managed under direction of ICPs. Communication and task delegation. Senior clinicians should ensure clear, concise communication is maintained throughout the entirety of the job. This includes delegating appropriate tasks to each clinician to ensure the patient receives the highest level of care. Transport making decisions. Senior clinicians should ensure the appropriate transport decision is made for the patient and they are transported to an appropriate hospital, which we discussed in the previous slide more in depth. And a debrief. Debriefing at the end of a complex medical presentation is essential and should be encouraged by ICPs. It encourages growth and future development and education of all clinicians. And there I've just listed my references I've used. Thank you for listening to my presentation.